Assalamualaikum. I am Dr. Muhammad Ali Rabbani. I am a lecturer and Part 2 resident of FCPS AFME. And today on the forum of Medicos Academics, we are going to discuss the review questions. We are going to review the questions of FCPS Part 1 from the topic of abdomen, pelvis, and perineum. For today's talk, we are going to use SK Golden 9 medicine and allied portion. And these are the questions that have been extracted from the 10 papers that are present in this section of the book. Bismillahirrahmanirrahim. I like to start my lecture with the quote that I used yesterday. If I have seen further in the future, it is by standing on the shoulder of the giants. So this video has been made possible with the help of content and illustrations obtained from other sources. I do not claim ownership of any of the material that is not mine, and due credit will be given to the original source to the best of my ability. Otherwise, the rest of the hard work is there. Inshallah, you will get help from that. So we are going to discuss today the abdomen, pelvis, and perineum, and this is the order of the things in which we'll take the lectures. First, we'll discuss abdominal wall, then cavity, and so on with the pelvic and perineum. So let's start with the abdominal wall. So this is thinker. The first question is again: the appendectomy is done by McBurney's incision, which structure is damaged? This is one of the very controversial questions on the social networking forums in which the people argue about which questions is right. So the key in uh, escapal is iliohypogastric nerve. So it is right. I'll discuss a little in detail why. At least in my opinion, there are three options that are partially right. The iliohypogastric nerve, ilioinguinal nerve, and deep circumflex iliac vein. These all the structures are present within the reach of ilio in the McBurney's incision. So first I'm giving the reference of last anatomy that says that iliohypogastric and ilioinguinal nerve may be between internal and oblique and transversus and must not be damaged. And similarly, incision laterally may cut deep circumflex iliac artery, ascending branch, and of course artery is accompanied by vein. So you must keep in mind that if given alone, any of the three answers can be right. Iliohypogastric, ilioinguinal, and deep circumflex uh, iliac vein. But now, mostly in past papers and in social networking forums, the comparison is between the ilioinguinal and iliohypogastric. So let me explain a little why iliohypogastric is a little preferred answer on ilioinguinal. So actually what happens is that ilioinguinal uh, is a little away from the McBurney's incision as compared to iliohypogastric. This is a reference of an article. I have given the reference on the top. You can see that they have said that both the nerves can be damaged, but in cadaveric incisions they saw that the distance between the incision and the nerve itself was more in case of ilioinguinal and less in case of iliohypogastric. So, and that same opposite goes true for the distance from anterior spheric iliac spine. So these give a little idea about why the iliohypogastric is a little first to be damaged. And this is another reference. I'm just leaving it here. You can pause it and read it here. This article has tried to give a little perspective about why iliohypogastric may be damaged a little earlier as compared to ilioinguinal, and it has given the same logic that iliohypogastric is nearer to the incision line. I'm just leaving it here if you are interested, and let me give you a visual example. So here you see that here is anterior spheric iliac spine, here is the umbilicus. So in between them, you'll draw a line between these 2 points, divide it in three parts, and the junction between the lateral and middle thirds is known as the McBurney's point. And here you like the McBurney's incision. Here you can see that this artery, this deep circumflex iliac artery, this is passing the line of the incision. So if a surgeon is not careful enough, deep circumflex iliac artery including vein may be involved in the incision. And similarly here, if you go, you can see that here is the line, and below the line there are these two nerves, iliohypogastric and ilioinguinal. But here you see that iliohypogastric nerve is a little uh, closer to the McBurney's incision line as compared to the ilioinguinal. So if I'm stressing on the word if we have to choose between the two, go for the iliohypogastric nerve. So that's why in this particular MCQ, iliohypogastric nerve is preferred, and deep circumflex iliac artery is not mentioned and vein is mentioned. So vein is has a little more variability. So you can choose iliohypogastric nerve, but I wanted to make it clear that either of the three, when alone, can be considered correct. Deep inguinal ring is in should be very much clear about which structure are forming deep inguinal ring and which are forming superficial inguinal. Here in the green is shown a defect in the transversalis fascia that is making the deep inguinal ring, and you should know that this transversalis fascia continues as internal spermatic fascia, and superficial inguinal ring is a defect in aponeurosis of external oblique. Let's move on to abdominal cavity, peritoneum. A lesser sac is situated between. There are a lot of questions about lesser sac. Let's discuss this one first. So anteriorly there is stomach and posteriorly there is pancreas. So lesser sac is situated between stomach and pancreas. Another question that is repetitively asked is the structures in the posterior wall of the lesser sac. See this picture. This is from the Netter's anatomy. Transverse colon, transverse mesocolon, pancreas, sphenic artery, celiac artery and its branches, part of left kidney, part of left suprarenal gland, and so on, part of diaphragm. Go ahead, read the points about which structures are in the posterior wall of the lesser sac. It is very frequently asked question. Liver is attached to the lesser curvature of the stomach. So the ligament that is between the liver and the stomach is round ligament. It's not hepatorenal, hepatogastric. Very simple. Lesser curvature of stomach and liver are attached by hepatogastric. It's in the name. Liver, hepato, stomach, gastric. Hepatogastric ligament. But for the purpose, you should know its other name, that is lesser omentum. That is very frequently used. And the second question that is very much frequently asked is that the part of the lesser omentum that connects the liver to the stomach is hepatogastric, and the part of the ligament that is between the part of the lesser omentum that is between the liver and the first part of the duodenum is known as hepatoduodenal ligament. And the number two, the question that is frequently asked is what are the structures that are present within the hepatoduodenal ligament? Go ahead and read them. Portal vein, hepatic artery, and there is portal vein, hepatic artery, bile duct, and accompanying lymph and nerves that are going there. So this is very frequently asked question, and this question is also asked in the way that uh, the structures in the free margin of the lesser omentum are. So it can be asked in either way. Liver attached to the ventral body wall. So the attachment of the liver with the anterior body wall, it is falciform ligament. Here you can see that anterior body wall connection falciform ligament. Another question frequently asked is the structure in the lowest margin of the falciform ligament, that is known as ligamentum teres, and embryologically which structure it is derived from, that is left umbilical vein. So these are the three questions that are very much frequently asked. What is falciform ligament? Here it is given, and in its lower margin there is ligamentum teres here, or round ligament of liver, and ligamentum teres or round ligament of liver is embryologically driven from left umbilical vein. Intrinsic factor is released by, you should be very clear, intrinsic factor is mostly by from the fundus of the stomach, and it is mostly the more important thing that you should remember is it is derived from the parietal cells. So parietal cell secretes intrinsic factor and HCl. The same question asked here. Parietal cell release intrinsic factor and HCl. Ileal dilator muscles are derived from. So it's a very simple question, just a brain exercise. You should know that there is mucosal layer, submucosal layer, muscular layer, and serosal layer in the GIT. And in the muscular layer, there is longitudinal and circular muscles. The circular muscles, they contract and narrows the lumen, they are constrictor muscles. And the opposite function will be obviously provided by the muscles that are dilator muscles. So these are longitudinal muscles. If circular muscles are going contraction, dilator will, longitudinal will do the dilatation. So here, this will be the answer. So this is the longitudinal answer. It decreases the length but increases the diameter. Peptic ulcer is most common location. Is most common in first part of the duodenum, because immediately the contents of the stomach are going here, and the acidic contents of the stomach do not get enough chance to get neutralized just in the immediate part. As they move on, they get neutralized and they become less harmful or caustic. Caustic, I think it's not a better word. Go for harmful. Posterior duodenal ulcer may erode and bleed due to. Yes, this is a very commonly asked question, and it has been asked a number of times in this particular exam also. The posterior duodenal ulcer usually it involves gastroduodenal artery. I'm sorry. Let me go back to over here. So posterior duodenal ulcer may it erode. You should be very much clear about that gastroduodenal artery. This particular picture is given in almost all of the major books in the Snell, Natter, Grace, whatever book you are reading. Go ahead and memorize this picture. You should know all the branches of the celiac trunk. You should know their relations and where are they going. So this is one of the branches of the celiac trunk that common hepatic artery gives rise to this gastroduodenal artery. It moves behind the first part of the duodenum to become the superior pancreatoduodenal artery. So gastroduodenal artery. Here it is passing behind the first part of duodenum. So posterior duodenal wall ulcer involves this artery. Blood supply to the middle esophagus is through. Again, this question is very much asked not just again about the middle part of the esophagus, but about the blood supply of the esophagus, all three segments. So in this particular case, the correct answer is descending thoracic aorta. But you must should remember that a first part of the esophagus is being supplied by inferior thyroid artery. The second part of the duodenum, the second part of the esophagus is being supplied by direct branches from aorta, and the third part and the lower third is basically supplied from the celiac trunk branch, that is left gastric artery. And another question that is not mentioned here is that sometimes the esophageal artery it is not derived from directly aorta. Here you can see that it may be sometimes derived from the right bronchial artery, the artery that is flowing the right bronchus, and right bronchial artery is itself a branch, sometimes a branch of third right posterior intercostal artery. So for this particular, the middle part of the esophagus, the answer may be descending aorta and or third posterior intercostal artery. Yeah, right bronchial artery. Be very vigilant about that because this question, even not asked about the esophagus, this question is asked much like that. If the right bronchus originates from third right posterior intercostal artery, and here you can see that esophageal branch of right bronchial artery is shown in the letter also. The liver attached to the ventral body wall by which ligament? Same question. Falciform ligament. Again, same question. Attached to the ventral mesentery. Okay. For embryological perspective, most of the GI tract has originally dorsal mesentery, but uh, due to the septum transversum, most part of the esophagus, throughout the stomach, and first part of the duodenum, they also have a ventral mesentery. In the ventral mesentery develops the liver, and when in the ventral mesentery develops the liver, so the part of the mesentery that is left between the liver and the stomach, that is known as lesser omentum, and the part of the ventral mesentery that is left between the liver and the anterior abdominal wall, that is known as falciform ligament. So liver attached to the ventral mesentery, again we will go for ligamentum falciform ligament. What lies posterior to the uncinate process of pancreas? Yes, uncinate process is a projection from the head of the pancreas. Here, uncinate process, it posteriorly it is related to the aorta. Here is the uncinate process here, and here behind it, it lies the aorta. Now, this question is asked in a variety of ways. What structure is right in the posterior relation of the uncinate process? It is aorta. What structure is related to the anterior surface of uncinate process? That is superior mesenteric artery and superior mesenteric vein. And which structure it relies anterior to the, it is also the root of the mesentery proper, root of the small intestine, because they are running in the root of the small intestine. Now there is a third way this question is asked. Which structure lies between the superior mesenteric artery and aorta? The answer will be uncinate process of the pancreas. Blood supply middle pass of esophagus, same question. So it will be descending thoracic aorta. Again, remember, don't forget the third right posterior intercostal. Upper one third of the esophagus is supplied by inferior thyroid artery, and the upper one third of the face is supplied by again inferior thyroid artery. Here it is very clearly shown in this picture. And left gastroepiploic artery is a branch of. I told you for that branch, so celiac artery is a very important one. Rather, I would like to say that the blood supply of all of the GI tract is very important. So the left gastroepiploic is a branch of. It is the branch of splenic artery. You see, this is the splenic artery, the wavy artery moving along the pancreas and moves to the hilum of the spleen. Here in this artery, left gastroepiploic, and its other name is left gastromental artery, that is supplying. Superior pancreatoduodenal, again, it is a direct branch of celiac artery, or not a direct branch of celiac artery, it's a branch of gastroduodenal artery. So celiac artery has three major branches. One, left gastric going up, splenic artery going here, common hepatic artery going on this side. Common hepatic artery further gives rise to right gastric, hepatic artery proper, and gastroduodenal artery. And then gastroduodenal artery further give rise to two arteries, that is superior pancreatoduodenal and right gastromental or right gastroepiploic. So you go for now. If you can say that celiac trunk is also correct, because ultimately the blood is coming from celiac trunk. Whenever you are given such a choice, always choose the answer that is nearer to the question. So, with superior mesenteric artery, superior pancreatoduodenal artery is a direct branch of this artery, not a direct branch of this artery. It is indirectly giving blood from celiac trunk. So you go for gastroduodenal. Posterior duodenal wall ulcer may damage with artery. Same question, gastroduodenal artery. Superior pancreatoduodenal artery arises from, again repetition, that is gastroduodenal artery. Right gastric artery is a branch of. We just saw in the previous discussion that right gastric artery, it is actually a branch of hepatic artery. You see here the hepatic artery, it gives rise to right gastric artery. Be very vigilant about the right and left gastric and right and left gastric epiploid. Both have drastically different answers, but sometimes a person does not registers the difference between the two. Artery behind the first part of the duodenum. The same question asked in a different ways. Gastroduodenal artery. Jejunum is being supplied by. Okay, now I'll give you a very brief key for the nerve supply, arterial and venous drainage. You should embryologically know the limits of the foregut, midgut, and hindgut. The foregut is originally from the point of your tonsils, that is your oropharyngeal isthmus, all the way through the esophagus, through the stomach, through the duodenum to that part of the second part of the duodenum where CBD opens. So if you demark a line at the point of CBD opening, everything behind it, everything before it is foregut. From the point where CBD is opening into the second part of duodenum all the way down, remaining duodenum, jejunum, ileum, colon, appendix, ascending colon, and initial two-third of the transverse colon. All of it is derived from midgut. Then the remaining what is left? The distal third of the transverse colon, descending colon, sigmoid colon, rectum, anal canal up to the pectinate line. All of it is derived from hindgut. Why I'm telling you this? Because all of the structures that are derived from foregut will ultimately have blood supply from any of the branch of celiac artery, ultimately will have lymphatics in the celiac nodes, ultimately will be supplied by the celiac nervous plexus. All of the part of the GIT that are derived from the midgut, yani midgut will be from the point of opening of CBD to the two-third of the transverse colon. So all of the structures will be originating, will have artery supply from various branches of spiromesenteric artery, drainage into the spiromesenteric vein, lymphatic spiromesenteric nodes, and nerve supply will be spiromesenteric nerve plexus. And very similarly, hindgut will have all the same supply. Branches of inferior mesenteric artery, branches of inferior mesenteric veins, lymphatics into the inferior mesenteric nodes and inferior mesenteric plexus. Now, jejunum is being supplied by, it is originally derived from midgut, so it is basically being supplied by ultimately superior mesenteric artery. Here you can see that superior mesenteric artery and jejunum and ileal branches that supply the said structures. Superior mesenteric artery supplies, again, you should know that it supplies the structures of the foregut. So it supplies basically DJ junction until two-thirds of the transverse colon. So this will be the correct answer. The better answer would have been if the second part of the duodenum to the two-thirds of the colon, but we will take what's given to us. Abdominal angina results from the blockage of it is from the superior mesenteric artery. When superior mesenteric artery is blocked, a large part of the small intestine, a bulk of the viscera of the GI tract, and they are involved, and the pain is there. Superior rectal artery is a branch of. You should know the branches of all of these. Not going into that detail, but you should know that it's a branch of inferior mesenteric artery. We saw the branches of celiac artery, the superior mesenteric had this ileal and jejunal branches, inferior pancreatoduodenal, and then ileocolic, right colic, this ileocolic, right colic, middle colic, and ileal jejunal and inferior mesenteric. And this inferior mesenteric had left colic, sigmoidal, and superior rectal. So superior rectal was asked in this question. Leading due to the portal hypertension. Scenario given the portal hypertension asks a lot of the vessels that are present as a part of portal system, and all of the branches of the portal system are exactly the same as the branches of the internal inferior mesenteric vein and superior mesenteric vein. So you should know the vessels that are part of portal system. So bleeding due to the portal hypertension. So again, portal hypertension will involve the structure where there is portosystemic anastomosis. Here there are two candidates, left gastric vein and superior rectal vein. We'll take the left gastric vein because it's involved early, but superior rectal vein is also a correct answer. Let's see why. There are three basic anastomoses, or two most important ones. In the lower third of the esophagus, there is an anastomosis between the left gastric vein, that is portal drainage, and then azygous venous system in the middle third, that is systemic. So there is esophageal varices develop when there is portal hypertension. In the rectum, there is anastomosis between superior rectal vein, part of inferior mesenteric, splenic, and portal vein, part of portal system, and inferior mesenteric vein, inferior rectal vein, that's part of systemic system, and their varices at anorectal junction form in the form of portal hypertension. And then at the level of umbilicus, paraumbilical vein, portal, and superficial vein of the abdominal wall, they anastomose and form the caput medusae. And the other connections are not very important. They are mostly at the bare area of the liver, at the retroperitoneal parts of the gut, and most of them, these are not very important. So here, both are the correct answers, superior rectal vein and the left gastric vein. We're just choosing the left gastric as it is more common. The right kidney hilum relation to the relations of the right kidney is very, very frequently asked. Right kidney hilum relations. So it is related to the hilum is related to the second part of the duodenum. Here you can see that hilum is related to the second part of the duodenum. It is related to the kidney is related to the liver and hepatic flexure, but it is not related to actually hilum of the kidney. Anterior relation of the hilum of the right kidney, exact same question, second part of duodenum. True about suprarenal gland. This question was given, I just put it here. The answer in the book was in the escapal, it was hypogastric plexus related to it. But in my humble opinion, I'll humbly like to object to this particular question. I think there have been some type of recall bias, because in my humble opinion, there is no correct answer, because inferior vena cava on either side. No, suprarenal gland does not have inferior vena cava on both sides. Yes, there is suprarenal gland on both sides of inferior vena cava. So maybe there's a grammatical mistake here. Both of the suprarenal glands are not related to central tendon. Suprarenal gland is not related to hypogastric plexus. It is related to the suprarenal plexus. So Due to these reasons, I'll humbly like to object that either of the answers are not correct. The nerves and plexus of abdomen. The supply of the suprarenal gland is through. It's not something to be understood as such. You just need to know the values. It's about T5 to T9. And surprisingly enough, this has been asked multiple times. Suprarenal glands supply. Okay, suprarenal gland, we just discussed that these are being supplied by the nerve level T5 to T9. So you should know the values of the splanchnic nerves. Greater splanchnic, lesser and least splanchnic. Greater splanchnic is from T5 to T9. Lesser splanchnic is from T10, 11 and least splanchnic is from T12. So your answer will be greater splanchnic nerve. The right renal vein drains into, it's a straightforward question. It drains into inferior vena cava. Another question that is frequently asked that's a little bit confusing is that the left suprarenal vein, the left testicular or ovarian vein, if they do not drain into the inferior vena cava, they drain into the left renal vein. Then there is greater splanchnic nerve association with the plexus. You should remember that greater splanchnic nerve directly goes to the celiac, and the lesser splanchnic nerve directly goes to the celiac or mostly to the celiac, and the least splanchnic nerve mostly goes to the renal plexus. And just to remember, this is a picture that may help you remember this point. So you can see that greater splanchnic nerve, they mostly go directly to the celiac plexus. Lesser splanchnic nerve, they mostly go to the celiac or aorticorenal plexus at the junction of the two. And the least splanchnic nerve mostly goes directly to the renal plexus along the renal artery. Other lumbar plexus, they go to the other plexuses around aorta, and then the pelvic splanchnic nerves mostly they go into the inferior hypogastric plexus. So our question was about greater splanchnic nerve. It goes to the celiac plexus. At bifurcation of abdomen, there is a nerve which passes from superior hypogastric plexus to the inferior hypogastric plexus. The nerve that joins the two plexi is hypogastric nerve. So this is the superior hypogastric plexus at the bifurcation. This is the inferior hypogastric plexus, and in between them there is hypogastric nerve. A woman presents with gastric ulcer and pain on xephisternum. Which nerve carries the pain to the xephisternum? You should know that at the level of umbilicus, the spinal segment that supplies is T10. At the level of pubic symphysis is L1, and at the level of xephisternum it is T7. But T7 is not here. The answer in the escapable key was T9 spinal nerve, but I humbly would like to object from it. My answer would be greater splanchnic nerve. I know it's a little out of the way, but still, greater splanchnic, in my humble opinion, it would be a better answer. As you can see that T7 is umbilicus level, xephisternum is this area is at T7. T9 won't coincide with this one, or T7 value it is only present within the greater splanchnic nerve. Basically, what happens is gastric ulcer. These nerves are carried by greater splanchnic nerve to the spinal nerve, and there they feel the pain is brain field at referred pain to the xephisternum. Greater curvature of the stomach, CLM. Greater curvature. The stomach has CA on the greater curvature, and which lymph node will be swollen. You should know the lymphatics of the stomach. The greater curvature mostly goes to the hair, and hair mostly goes to the splenic nodes, and splenic nodes through here they ultimately goes to the celiac plexus, celiac nodes. So your answer will be celiac nodes, but you should know that a little part of the greater curvature just near the lower end, it may go to the spiromesenteric nodes also. But mostly for the major part, this whole line it drains through the splenic node into the celiac node. Lymphatic from stomach drain into mostly just remember the foregut, midgut, hindgut formula. Mostly they go into the celiac nodes. Fundus of the stomach drain into again the same story, celiac node. But you should know that they first go to the splenic nodes. It was not asked go ahead for celiac. Appendicular lymph nodes. Again remember the foregut, midgut, hindgut formula. So it was midgut in origin, then superior mesenteric nodes along with the blood supply of the spiromesenteric artery. Then pelvic wall, there are a few questions there. Pelvic common in males, most common in males is android type. android and anthropoid type. These are most common in males, and gynecoid type is most common in females. Same question repeated. Discuss the pelvic cavity. Here the first question is the sacral segment is damaged. It will lead to what? Atonic bladder, decreased bladder capacity, spastic, autonomous bladder. You should know that if you just look at the picture, there is a simple circuit of the bladder, simplest circuit to for the academic for the understanding purpose. And the sensory innervation, the afferent fibers shown in the black here, they go with the pelvic nerve, pelvic splanchnic nerve, all the way to the sacral segments, and they go into the sacral spinal segments that are S2, 3, and 4. Here, with the help of interneuron, they synapse with the parasympathetic outflow, that is pelvic splanchnic nerve, and through them all the way it goes back to the bladder, and it leads to the contraction of the detrusor muscles of the bladder. So, if there is no other nerve in picture, there is this simple most function happens. Bladder expands, there is sensory innervation, it triggers this reflex, and pelvic splanchnic parasympathetic fiber they lead to the contraction of the detrusor muscle. There are other factors in play like pudendal nerve relaxing this external urethral sphincter, and sympathetic fibers relaxing internal pudendal, but we are internal sphincter, but we are not going to discuss that. Just afferent fibers activating the reflex and efferent fiber contracting the detrusor muscles. So what happens is that normally as you grow, this simplest thing that occurs in the neonates, as the urine fills in 1 to 2 hours, 1 to 4 hours, this reflex is activated and they void the urine. But what happens in adult is as you grow old, the higher the descending tracts from the upper region of the central nervous system, they have a negative influence or they have suppressing influence on these segments. And they have a suppressing influence, they help us to consciously inhibit this reflex to the point when we are comfortable in doing so. So when we have a place where we can go and void, then this inhibitory reflex is lifted off and this reflex can function and you urinate. What happens is that when this segment itself is being damaged, now this simple reflex arc is damaged. The in the sensory signal does not initiate automatically activates the contraction of the detrusor muscle. So there is no activation of the detrusor muscle. It will lead to the atonic bladder. In my opinion, it leads to the atonic bladder. This one it was given in the original key of the escapal, but I would like to say that in my opinion, atonic bladder will be the correct answer. You can always check the book, and if you think there is a problem in that, you can always counter argue, or we can discuss that in detail also in the comment section if you need so. Micturition reflex regulation, pons medulla sacral plexus. Sacral plexus will be a preferred answer as it contains both the pudendal nerve and pelvic splanchnic nerve. All of these nerves, these are being exiting from the sacral plexus. uh, Pons, it has pontine micturition center, but it is not so much of a regulator. It when it is activated, it leads to urination. It's the center that organizes the voiding of the urine. So it's a detailed topic. We'll not go into the much detail. So let's skip on voluntary inhibition of the micturition reflex. Voluntary inhibition, it is mostly through the pudendal nerve. Pudendal nerve, it helps in like ignore this picture. You see this picture, pudendal nerve. It leads to the innervation of the external urinary sphincter, and this helps in the contraction of the urethra and constriction of the urethra and helps in control. So voluntary inhibition is through the pudendal nerve. I'll be not be discussing this particular picture. It will be a separate talk if you need it to be. Voluntary inhibition of the micturition reflex is through again increased pudendal nerve traffic. Here pudendal nerve seen. It you voluntarily constrict the external urinary sphincter. Injury above the sacral spine. When there is injury above the sacral spine, like there is thoracic, initially what happens is there is spinal shock. When there is spinal shock, there is atonic bladder. But as the effects of the spinal shock they go away, what happens is that the tone of the muscle it increases because the inhibitory effect from the descending fiber it has been removed. So the bladder becomes spastic. and fall from a cycle. Patient is unable to pass urine for 2 days. Structure injuries. Most likely in this case there is an injury in the pelvis, and injury in the pelvis most likely damages urethra, especially in the boys. It's true. The urethra is longer and it is prone to injury, and when there is injury, the urine does not come out of the normal tract. It leaks inside. So that will be the correct answer. For all the other cases, there will be some urine leakage, there will be some drainage of the urine from the urethra, not complete. There will be inside leakage, but there should be some. Artery involved in tubal ligation. Whenever there is fallopian tube is being ligated, the branch of uterine artery, tubal branch of uterine artery, these are most commonly involved in tubal ligation. Same question, tubal ligation, artery that is ruptured, that is uterine artery. Whip-like motion is on which organ? Whip-like organ is through the fallopian tube. This fimbria of the fallopian tube, in the most initial portion, it sweeps over the surface of the ovary and it picks up the ovum and it is ovulated. Ectopic pregnancy most likely. Most commonly it is in the fallopian tube, and you should know that most common site in the fallopian tube is ampulla. And most common site outside the reproductive system, outside it is the pouch of Douglas. Okay, that's it for now. Thank you so much. For more videos, subscribe to our Facebook page and YouTube channel. If you have any further questions, suggestions, and or complaints regarding this topic, kindly post in the comments below. I'll try my level best to answer them satisfactorily. And I'm very much open-minded against criticism. If you have any objection about my way of teaching or any content, if you find it inaccurate, please do tell me. Thank you so much. We'll see you in the next video, inshallah. Allah Hafiz. Good night.